Hey guys, it's Prabdeep here with channel Ace Pants. Today I made a small quiz for you guys, which is made up of about 20 questions to see if you guys are ready for pants or not. Alright? Now the purpose of this quiz is not to tell you how well you're going to do on the exam, but to rather tell you if you're not ready for the exam. Now what I mean by that is, let's say you scored 20 out of 20 on this quiz. Now that doesn't mean that you're going to do extremely well on the pants, right? But if you score less than 70, then that means you're not ready for the exam, okay? So the purpose of the exam is to see if you can score above 70 or not. If you do, then good. If not, that means you need a lot more work to be done. And if you're planning on to taking the pants, then I would recommend delaying it and putting in some work, more work before taking the exam. All right. I hope you guys understand that. Also, between each question, I'm only gonna pause the video for 10 seconds. I know normally we have 1 minute per question for during our exams, but if I do this for this video, then that'd be 20 extra minutes, and that's just too long for this video. So I'm gonna stop the video for 10 seconds, and during that time, if you feel comfortable answering the question, then that's fine. If you don't, if you want to take the full minute, you can pause the video and time yourself. That's completely fine. Okay, that's okay to do, because normally we have 1 minute to answer each question. And now after every question, I'm gonna give you the answer and a proper explanation. And I really hope you guys like this video. And now before we move on, do not forget to smash that like button, subscribe, and hit the notification bell for future videos just like this one. And yeah, let's get started, guys. Question number 2. Which of the following is a contraindication for sublingual nitroglycerin? A. Anterior wall MI. B. Stable angina. C. Inferior wall MI. D. Anterolateral wall MI. E. Unstable angina. 10-second, guys. Alright, so the answer here is C. Inferior wall MI. Inferior wall MI, especially if it involves the right ventricle, is very preload sensitive. That's why drugs like nitroglycerin and morphine should be avoided, because in these cases it decreases the preload even more. It shifts the volume that's supposed to come into the right ventricle and puts it out in the periphery. So that's why you need to avoid these drugs and make sure these guys are resuscitated properly, alright? So they need to be on IV fluids. That helps out with inferior wall MI a lot in terms of management. Question number 3. Patient develops consolidations on chest section on the 4th day of the hospital admission. When deciding on the antibiotic regimen, which microbe should be most importantly covered? A. Streptococcus. B. H. influenza. C. Legionella. D. Pseudomonas. E. Mycoplasma. 10-second, guys. If you guys need to take longer, you need to pause the video. You can take up to a minute, okay? Alright, the answer here is D. Pseudomonas. Now, any consolidation that is seen within 48 hours of the hospital admission is considered community acquired. Anything above 48 hours is hospital acquired. And the most common cause of hospital acquired pneumonia is Pseudomonas. Alright? Streptococcus most commonly causes community acquired pneumonia. Same thing with H. influenza, but is more commonly seen in patients with COPD. Legionella is commonly seen in contaminated water. So in clinical vignette, you might see air conditioning system in an old building that makes patient prone to getting pneumonia. Mycoplasma is the most common cause of atypical pneumonia. And in clinical presentation, you might see something like pharyngitis or bullous meningitis. So look out for that. Question number 4. What is the most likely underlying cause of the pathology shown in the radiographic imaging? A. Streptococcus. B. H. influenza type B. C. Bordetella pertussis. D. Parainfluenza virus. E. RSV. 10-second, guys. So the answer here is B. H. influenza type B. So what we have here is epiglottitis. And the most common cause of epiglottitis is H. influenza type B. The structure here that you guys see, hold on, is the epiglottis. And in epiglottitis, you will see something called thumb sign, alright? This is the swollen epiglottitis, and it will appear as thumb sign on imaging, alright? And as we spoke before, streptococcus is the most common cause of community-acquired pneumonia. Bordetella pertussis causes whooping cough. parainfluenza virus causes something called croup, which is inflammation of the trachea and the larynx. And on cervical x-ray, you will see a classic finding, steeple sign, which is basically narrowing of the airway. RSV most commonly causes acute bronchiolitis in children. Question number 5. Acute onset of peripheral neuropathy in a TB-positive patient is a result of which of the following TB drugs? Rifampin, isoniazid, pyrazinamide, ethambutol, or streptomycin? 10 seconds, guys. Alright, the answer here is choice B, isoniazid. Now, keep in mind, guys, chronic use of isoniazid causes vitamin B6 deficiency. Because of that, you can have peripheral neuropathy, you can have like burning sensation, numbness and tingling in your upper or lower extremity. In rare cases, you can have central symptoms like ataxia and nystagmus, but mostly it will be peripheral neuropathy. Now, this is only with chronic use. In acute cases, for example, if the patient overdosed or if they took extra pills to compensate for a missed dose, in those cases, you will have central symptoms. It will be more of a severe presentation. These patients will come in with seizures or altered mental status, and that you can see that with acute cases. So just make sure you know the difference between acute and chronic and toxicity with INH. Question number 6. Elevated thyroid stimulating hormone and low free thyroxine is indicative of which of the following? A. Primary hypothyroidism. B. Primary hyperthyroidism. C. Thyrotoxicosis. D. Secondary or tertiary hypothyroidism. E. Secondary or tertiary hyperthyroidism. You guys have 10 seconds to answer the question. Alright, the answer here is A. Primary hypothyroidism. So, low free thyroxine means there's low thyroid hormone. So, meaning it's hypothyroidism. So, in that case, you can eliminate choice B, you can eliminate choice C, and E. So, you're left with either choice A or D. So, now all you need to know is whether the issue is primary or secondary. Okay? Now, I want you to look at this axis before we discuss that. So this axis starts with the hypothalamus, which releases thyroxine releasing hormone, which acts on the pituitary to release thyroid stimulating hormone, and this acts on the thyroid gland to produce thyroid hormones. Now these thyroid hormones are picked up by the pituitary and the hypothalamus, and they act based on the levels of these thyroid hormones. If the levels are decreased than what they would like to be, then both the hypothalamus and the pituitary will increase the production of TRH and TSH, so more thyroid hormones can be produced. If there's increased amount, then they will stop producing TRH and TSH because they don't want the thyroid to be stimulated to produce more hormones. So in our case, we have low thyroid hormones. Now in that case, the production of TRH and TSH should go up. And in return, the thyroid hormones should increase as well. But that's not the case, right? Because we saw there's low thyroxine and there's high TSH. So we know pituitary and the hypothalamus are working just fine, but there's an issue with the thyroid gland because it's not reacting to what the pituitary and the hypothalamus is telling it to do. So in that case, it's primary hypothyroidism, right? Let's say now that you had low thyroid hormone, right? But instead of this TH being increased, it was decreased. Meaning, the problem here is at the pituitary level, right? The pituitary picks up that there's low thyroid hormone, but it's not increasing the production of TSH. Therefore, not stimulating the thyroid hormone to increase the production. So this is an example of secondary hypothyroidism. Now, I don't want to go into any more detail because it will get confusing, but I hope you guys get the gist though as to what I'm talking about here. Okay? Question number 7. New onset of peripheral neuropathy along with anemia is indicative of which of the following? Folate deficiency, vitamin B6, anemia of chronic disease, iron deficiency, vitamin B12 deficiency. 10 seconds, guys. Alright, so the answer here is vitamin B12 deficiency. Both vitamin B12 and folate play a key role in DNA synthesis and therefore are responsible for forming RBCs, white blood cells, and platelets. If there's significant amount of deficiency in either one, you can have pancytopenia. But most commonly, it will just present with macrocytic anemia. The key difference between folate and vitamin B12 is that vitamin B12 will have neurological symptoms. But if you give a vitamin B12 deficient person folate supplements, if you misdiagnose them and you give them folate, the anemia will resolve. However, the neurological symptoms won't. All right, so in that case, you have to give them B12 in order to resolve the underlying neurological issue. Now, vitamin B12 is present in animal products only, whereas folate can be seen in both animal and plant products. So in that case, if a patient is vegetarian or vegan, just keep in mind that they might have vitamin B12 deficiency if they're coming in with anemia. Something to keep in mind. Question number 8. Which of the following is the most sensitive test for acute pancreatitis? A. Amylase, B. Lipase, C. Bilirubin, D. Alkaline phosphate, E. Gamma-glutamyl transferase. 10 seconds, guys, and then we'll go over the answer. Alright, so the answer here is lipase. Lipase is the most sensitive test to diagnose acute pancreatitis. Now, this only applies to acute phase. If the patient is having chronic pancreatitis, then lipase is not very reliable, okay? Because the parenchyma gets destroyed and it's not able to produce the lipase, and therefore we can't really rely on it to diagnose pancreatitis in that situation. Bilirubin, alkaline phosphate, and GGT are more useful for biliary disease. Question number 9. What is an absolute contraindication for usage of ACE inhibitor? A. Cough, B. Anemia, C. Liver cirrhosis, D. Pulmonary edema, E. Bilateral renal artery stenosis. You have 10 seconds, guys. Obviously, guys, if you need more time, 1 minute per question. That's how much time we have for Pance, and you're more than welcome to use that here as well. No rush. Alright, so the answer here is E, bilateral renal artery stenosis. So the two absolute contraindications for usage of ACE inhibitor are angioedema in the past from ACE inhibitor, and obviously the renal artery stenosis. It has to be bilateral. In terms of choice A, cough is a side effect. It's not a contraindication for ACE inhibitor. Liver cirrhosis doesn't really matter because ACE inhibitor are excreted through the kidneys. Question number 10. What is the treatment of the rhythm shown above? Amiodarone, IV magnesium, cardizem, synchronized cardioversion, or unsynchronized shock? 10 seconds. Alright, the answer here is B, IV magnesium. The rhythm that we're looking at is Torsades de Pointes, and the treatment of choice for it is IV magnesium. It's caused by electrolyte abnormalities like low magnesium, low potassium, and in rare cases low calcium. And the treatment is with IV magnesium. Question number 11. 72-year-old woman with history of hypertension and CHF comes to the hospital for chest pain, lightheadedness, and palpitation. Patients noted to be hypotensive and tachycardic. On ECG, irregular rhythm is noted. What is the best treatment? Vagal maneuver, digoxin, beta blockers, synchronized cardioversion, or unsynchronized cardioversion? All right, take 10 seconds, guys. If you guys need more time since it's a longer question, you're more than welcome to do so. All right, so the answer here is D, synchronized cardioversion. Now, you guys know that irregular rhythm is indicative of atrial fibrillation. And this patient is clear that she's unstable. Okay, she's having chest pain, she's hypotensive, and she's tachycardic. And urgent synchronized cardioversion is needed in settings of acute ischemia, shock, or severe heart failure, and hypotension. So in this case, urgent synchronized cardioversion is needed to convert the patient back to normal. Otherwise, protection from thromboembolic events takes precedent over restoring normal rhythm. Question number 12. What is the most common precipitant of Guillain-Barré syndrome? A. Campylobacter, B. Cytomegalovirus, C. Epstein-Barr virus, D. HIV, E. Zika virus. 10 seconds. Alright, so the answer here is A. Campylobacter. It's the most common cause of Guillain-Barré syndrome. Question number 13. Identify the pathology shown in the CT head. A. Epidural hematoma, B. Subdural hematoma, C. Subarachnoid hemorrhage, D. Intracerebral hemorrhage, E. Normal pressure hydrocephalus. Take 10 seconds. Alright, so the answer here is A. Epidural hematoma. The lens-shaped or the biconvex pattern seen in the CT head is indicative of epidural hematoma. It has a limited expansion superiorly and inferiorly because of the dural attachments to the cranial sutures. And because it can't expand superiorly and inferiorly, it expands into the parenchyma, causing a sudden increase in intracranial pressure. And that for that reason, it's a surgical emergency. Whereas subdural hematoma is a crescent-shaped pattern, so it can expand superiorly and inferiorly without putting too much pressure on the parenchyma, and it gives you more time for the patient to diagnose, for you to diagnose the patient, and for them to compensate for the increasing volume inside the cranium. See, subarachnoid hemorrhage is characterized by a star pattern, so you will have bleeding into the subarachnoid space, and it will present as a star pattern here in the middle. Intracerebral hemorrhage is going to be bleeding into the parenchyma. So you'll see bleeding here inside the brain parenchyma. Normal pressure hydrocephalus, you have enlarged ventricles, which in this study you can't see because they're compressed and completely collapsed because of the increased pressure from the ventricle. You can see it slightly here, but they're almost obliterated by this hematoma, large hematoma. Question number 14. 32-week pregnant woman presents with vaginal bleeding and cramping abdominal pain status post-fall. Denies loss of consciousness or head trauma. The ultrasound shows retroplacental hematoma. What is the most likely diagnosis? A. Subchorionic hematoma, B. Uterine rupture, C. Spontaneous abortion, D. Placenta previa, E. Placenta abruption. Take 10 seconds. So the answer here is E. Placenta abruption. Painful bleeding after 20 weeks of gestation and setting of some sort of uterine pathology or trauma is indicative of placenta abruption. Alright? And if you see retroplacental hematoma on the ultrasound, that's classic for placenta abruption. Now, on the other hand, placenta previa is similar. It has bleeding after 20 weeks of gestation, but it's usually painless. So that's the classic difference between previa and abruption. Abruption is painful bleeding, previa is painless. Question number 15. 50-year-old man presents with acute onset of low back pain, saddle paresthesia, urinary incontinence, and lower extremity weakness. DTR, motor, and sensory function of the lower extremity are noted to be decreased. What is the most likely diagnosis? A. Vitamin B12 deficiency, B. Peripheral diabetic neuropathy, C. Quad Aquina syndrome, D. Multiple sclerosis, E. Guillain-Barré syndrome. The answer here is C. Quad Aquina syndrome. Quad Aquina is a serious pathology, but it's very hard to detect. The symptoms associated with the quad aquina are very common complaints and have multiple causes. And not to mention, these complaints can be hard and embarrassing for the patients to share, so they often go unnoticed. The classic group of symptoms that are associated with the syndrome are saddle paresthesia, lower extremity weakness, lower back pain, urinary and bladder dysfunction. The urinary dysfunction can present as either retention or incontinence, and the retention is often painless. These patients can also have erectile dysfunction. The onset of these symptoms can vary. They can be either insidious or gradual, making the process of diagnosis even harder. On exam, you'll find the following findings. They will either have decreased perineal sensation, decreased anal tone, motor weakness, sensory deficits, or even decreased DTRs. DTR meaning deep tendon reflexes. And the management involves immediate neurosurgical consultation for surgical decompression. Question number 16. Which of the following clinical finding on ultrasound is indicative of acute cholecystitis? A. McBurney's point. B. Murphy sign. C. Cullen sign. D. Rosving sign. E. Pessoa's sign. 10 seconds, guys. This is an easy one. Alright, so the answer here is B. Murphy sign. So the way you do Murphy sign is you firmly place your hand at the costal margin over the right upper quadrant. But during ultrasound, instead of the hand, you put the ultrasound probe and you ask the patient to take a deep breath and hold it. If during this time they have pain because of the inflamed gallbladder, then the patient has a positive Murphy sign. And especially on the ultrasound, if they have a positive Murphy sign, then that's indicative of acute cholecystitis. Because when you're doing this on your exam, you might not be able to, especially if the patient's obese, you might not be able to directly get right over the inflamed gallbladder. But you can do that during ultrasound because you can visualize it with the probe. So that's why positive Murphy sign on ultrasound is indicative of acute cholecystitis, and this patient is going to need a laparoscopic cholecystectomy. McBurney's point, Rosving sign, and Pessoa's sign, all these three are indicative of acute appendicitis. Cullen sign is seen with intraperitoneal hemorrhage, and usually these patients will have periumbilical ecchymosis. Question number 17. 53-year-old female with history of diabetes, peripheral vascular disease, and hypertension presents to the ED for redness and pain over the right lower extremity for 3 days. Patient is also complaining of fever and chills and states that the symptoms have worsened since the onset. On exam, erythema and crepitus are noted over the lateral aspect of the shin, and the region is extremely tender to palpation. On the X-ray of the right lower extremity, subcutaneous area is seen at the affected site. Given the findings, what is the most likely diagnosis? Cellulitis, abscess, pyoderma, necrotizing fasciitis, or DVT? 10 seconds, guys. For this question, if you want to take a full minute, you're more than welcome to do so. It's a long question. So you can take a minute if you need more time to go through the question. The answer here is D. Neck fash. The definitive diagnosis of neck fash is made through either a CT scan or surgical exploration. If there's crepitus on your exam or if the patient is rapidly deteriorating, then surgical intervention should not be delayed over getting a CAT scan. This is a surgical emergency. Early and aggressive surgical exploration and debridement can reduce the mortality and possibly even be limb-saving. IV antibiotics alone, without surgical intervention, results in 100% mortality. Question number 18. Obese 12-year-old boy is brought in by his mother for dull and aching right hip discomfort for 3 weeks. Due to the pain, the gait is altered and patient ambulates with a limp. Both the gait and pain worsens with activity. He denies any sort of trauma prior to the onset of the pain. On exam, internal rotation and flexation are limited of the affected limb. Vital signs and labs are within normal limits. What is the most likely diagnosis given the clinical presentation? A. Leg calf-Bertie's disease. B. Skiffy. C. Septic arthritis. A. Osteomyelitis. E. Idiopathic chondrolysis. 10 seconds, guys. So the answer here is B. Skiffy. So the classic clinical vignette for Skiffy is going to be an obese adolescent complaining of not radiating dull aching pain in the hip, but it can also be in the hip, groin, or the knee. They will have no history of trauma. Their symptoms will worsen with physical activity and improve with rest, and it is commonly unilateral, and patients have an antalgic gait. Leg is usually held in an extremely rotated position and may be shorter than the unaffected leg. Once you suspect the diagnosis and confirm it with x-rays, then prompt surgical intervention is needed. And during this time, patients should be kept non-weight bearing to avoid further slippage. Now, as comparison to this, leg calves is seen in a younger age group, and the onset is more insidious, unless like skiffy, and it does not improve with rest or even pain meds of that matter. And in terms of septic arthritis and osteomyelitis, these patients will have other systemic symptoms like fevers and chills. They will have a white count. So in this case, the vital signs and labs were within normal limits. There were no complaints of fevers and chills. So that rules out septic arthritis and osteomyelitis. Idiopathic chondrolysis will have, on exam, you will see that all range of motion are limited, not just like internal rotation or flexation. All range of motion are limited. So that crosses out E, and you are left between leg calves and skiffy. Question number 19. Which microbe most commonly causes meningitis between ages 18 to 50, and what is the best empiric regimen? A. Streptococcus pneumoniae, being treated with ceftriaxone with vancomycin. B. Neisseria meningitidis with ceftriaxone and ampicillin. C. Group B Streptococcus with ceftriaxone and vancomycin. D. Listeria, treating with ceftriaxone and ampicillin. Take 10 seconds, guys, and we'll go over the answer. Alright, so the answer here is A. Streptococcus pneumoniae, being treated with ceftriaxone and vancomycin. Streptococcus is actually the most common cause of community-acquired meningitis, followed by Neisseria, Group B. And if you're above the age of 50, then you're at risk of getting Listeria, and for that case, you will need to treat them with ceftriaxone and ampicillin. Now, ceftriaxone gives good coverage for all the common causes of meningitis, but the reason why vancomycin is added is because in the United States, the resistance to ceftriaxone is above 1%, and for that reason, you need to add vancomycin. So you kind of have to look at, each country's, statistics, and if their resistance to ceftriaxone is above 1%, then you would have to add vancomycin. And if they don't have that, if the resistance is less than 1%, then you can just simply treat it with ceftriaxone. But that's going to vary from country to country. But in the United States, you need to treat with ceftriaxone and vancomycin. Question number 20. What is the preferred diagnostic modality to rule out suspected nephrolithiasis? A. Abdominal X-ray. B. Bilateral renal ultrasound. C. CT abdomen pelvis with PO and IV contrast. D. CT abdomen pelvis with only IV contrast. And E. CT abdomen pelvis without contrast. 10 seconds, guys. This is the last question. We're done. Almost done. Alright, so the answer here is E. CT abdomen pelvis without contrast. Now, the reason why we don't want to give any contrast when trying to rule out stones is because the stones and the contrast light up in the same way. So it's going to obscure the study. So for that reason, you want to do a study without contrast. Now, a urologist might ask you to contrast and do a delayed study, but that's a little more complex. For studying, and I guess for exam purposes, CT abdomen pelvis without contrast is the way to go to rule out kidney stones. Or even if you're outpatient or in ED, CT abdomen pelvis without contrast should be the first step in ruling out kidney stones. Alright, that was the last question, guys. I hope this was helpful and you guys did well on it. If you scored 70% and above, good job. If you didn't, that's okay. Just need to put in more work. And I'm also available to help out. You can DM me, you can comment below, and I'm always willing to help out. Alright, I'll do whatever I can from my end. And yeah, that's it, guys. Please help me out with the YouTube algorithm. Like the video, subscribe if you haven't already, and turn on the notification bell for future videos. Whenever I post, it will just notify you. And that's it, guys. Please stay safe, stay tuned, and I'll be back soon. Take care. With the YouTube algorithm, smash that like button, subscribe, and hit the notification bell for